emergency room setting for about a year and a half after that. But really started to develop this interest in infectious diseases during the pandemic and, following along everything that was going on with COVID. So a chance came to kind of make a change in my career in July of 2021, and I took it, and I've been practicing as a infectious disease nurse practitioner in the community hospital setting for going on 3 years now.
That's amazing. So how did going from the emergency department into infectious disease, where did the interest in penicillin allergies come in?
So I think penicillin allergies is interesting because it's something that we encounter across kind of all specialties that we work. And I think it's a broad topic that, whether you work in an inpatient setting, an outpatient setting, the emergency room, urgent care, you're always going to encounter somebody with a penicillin allergy. I know myself when I worked in the emergency room setting and you see patients presenting in like a septic shock state that you want to start broad spectrum antibiotics and you want to do something like a Zosyn or a cefepime, but they have that listed penicillin allergy in the chart that's very nonspecific. It just says penicillin causes rash. You're not quite sure what to do with it because you don't want to cause any harm to that patient, but at the same time you want to treat them and manage whatever potential infection they have. So I never really knew what to do. And then when I got into infectious disease, I kind of learned a little bit more about how to assess somebody with a penicillin allergy, the right questions that you can ask. I ultimately ended up looking into it a little bit, learning how to do it on the job, talking about it on like a blog that we used to have for the Pennsylvania Nurse Practitioner Association that I belong to. And that kind of spiraled into me writing articles on it. I've spoken on a few podcasts about it and given a talk at a couple conferences now.
That's great. And we're so glad you're joining us here. Now, in practice, I've had so many patients that have reported penicillin allergies, and some of them I think are well-founded. They report a history of something like anaphylaxis. Sometimes it's a rash, and sometimes it's been a patient had an ear infection.
Yeah.
And then they were treated with an antibiotic, and a couple days later they broke out in a rash. And I always thought that was probably more like a viral exanthem.
Yes, yeah, you're quite right with that. We see a lot of these penicillin allergies start in childhood in the exact scenario that you just gave. The child comes to the pediatrician office with some upper respiratory symptoms. They get an examination done. Their ears look a little red. The provider, whoever may be seeing them, wants to treat them with some amoxicillin because there's this concern that there could be like a bacterial otitis media present there. So they get started on amoxicillin, but they incidentally just develop this rash the next day. Is it really the amoxicillin that caused that rash, or is it just kind of the course of their viral illness and they just so happen to get this viral rash at the same time that they started the amoxicillin? And the important point with that is a lot of those penicillin allergies will then stay on that person's chart for years to come, because moving forward, every time they go to the pediatrician office, they'll hear their parent tell the provider, nurse, whoever's checking them in, asking them about prior allergies, that they have an allergy to penicillin. And then ultimately, when that person is an adult and they go to a PCP office visit, the first thing they're going to tell somebody when they're asked about allergies is they're allergic to penicillin.
And that sticks with them for the rest of their life.
It does.
For us as providers, it's a challenge because when you are presented with a patient that has a reported penicillin allergy, how do you treat that patient? It kind of complicates things, and
it does.
To use different drugs that may be less favorable and are a little bit riskier.
Yes, I mean, the big thing that happens with the reported penicillin allergies, a lot of people want to avoid other beta-lactam antibiotics too, because a lot of times we were told that there was that 10% chance that if somebody was allergic to a penicillin, that they were going to be allergic to a cephalosporin as well. That's been shown to be really overestimated. A lot more modern literature on it has suggested that it is really as low as like even less than 1%. A lot really kind of fall in the 1 to 2% range for that. So it has been grossly overestimated in the past, and a lot of people who have had even true prior reactions to penicillin can safely get a lot of cephalosporins still.
Oh, that's great to know. That's very good information. And there are lots of different penicillins out there as well, right?
Yes, exactly. Penicillin is a family on its own. There's different classifications of penicillin antibiotics. Beta-lactams all share a similar central beta-lactam ring. That's, what makes them all similar, but they all have their unique chemical side chain as well, which really drives decision-making with future antibiotic use in people who have had prior reactions. You can compare the chemical side chains between two different beta-lactam drugs. If they're grossly different from each other, you more than likely can use that secondary agent safely and effectively without causing the patient any harm or chance of reaction.
That's great to know. Now, I want to get into more detail about how you assess and treat these allergies and determine if they are true allergies at all. But what are some of the reactions that you've had people report to you that they have when they've taken penicillin?
I mean, I feel like you can see a whole host of reactions. People can have minor dermatologic reactions like skin rash that occurs a couple days after starting the drug. They can have, true IgE-mediated anaphylaxis. And then it can be just as simple as somebody reporting like, oh, penicillin makes me nauseated. Penicillin makes me, it gives me yeast infections. It makes me anxious. It can be a whole lot of like other just normal side effects from the drug, not true allergic reactions.
So it's an allergic reaction versus an unwanted coincidence side effect from the medication.
Yes.
And so you as a provider, how do you start to dig into that and determine what's going on with this patient?
Exactly. Like, that's a great question. I think the area that I like to start with on that is just asking the right questions about that drug. We see a lot of these penicillin allergies listed in the chart that are very non-specific. It will say penicillin rash or penicillin nausea, penicillin hives. You don't really have great differentiation on what happened with that. So, I always start by asking them what drug specifically caused that, because penicillin is a very broad term. Penicillin could mean the whole family of penicillins. It could also mean penicillin the drug, because there is still penicillin used today. So I often start by asking them specifically which penicillin antibiotic caused the reaction, and then what happened exactly when they took it, as they can remember, because a lot of these happened in childhood and it's hard for people to remember. But, a lot of people remember if it, was it just a rash that you stayed home with, or was it like head to toe hives that you had difficulty breathing, that you went to the emergency department and you were treated for anaphylaxis with IM epinephrine, some IV Benadryl, other things that you would commonly treat anaphylaxis with. So I think it's important to establish what drug it was, what the exact reaction was, and then when did this happen? And when I say when, I mean more historically. Was this 5 weeks ago or 5 years ago? A lot of these reactions to penicillins and other antibiotics, it's typically suggested that around 5 to 10 years, people will have a change in their reaction to that drug, and they might not have that same reaction anymore. A lot of studies have shown that around 80% of people, even with true IgE-mediated anaphylaxis, will eventually grow out of that reaction.
That's reassuring, too. And I've had some patients tell me, everyone in my family is allergic to penicillin, so I don't want my child to take it, or my child's behavior changes when they take it. And so I think a lot of this is communication, taking the time to communicate with the patient.
Yes. So I think it's when it's like a reported side effect like nausea or something like that, I give the patient strategies for how they can overcome that nausea, take the medication with some food to prevent some of those GI side effects. If it's something like severe nausea and they can take Zofran safely, maybe give them an anti-nausea medication while they're on that antibiotic. A lot of things like the family history, there hasn't really been an established like genetic component to penicillin allergies. So that's not really like a true reaction in itself either.
Mm-hmm. What do you say? Some people say the first time I took it, I had an allergic reaction. Things can always change. People, there are people who can have like relapses with reaction that they did have at the first time they took it, they reacted. Then, they take it again and they do okay with it. And then they take it a third time and they react again. So like your reaction to a drug most certainly can change over time. And so you're in infectious disease. You are seeing, I assume, several different types of infectious diseases.
Mm-hmm.
How do you take the time to talk to each of your patients to really break this down? Or what is your process that you go through when you are practicing?
So in the inpatient setting, I will start by asking all of those right questions. People will fall as you ask those questions and figure things out. They fall into categories of risk, which are either low risk, moderate risk, or high risk. And then there are a select group of patients that should maybe avoid future exposure to that agent just because their reaction was so severe in the past. That would be someone who's had like a Stevens-Johnson syndrome or a similar reaction like that. Once you kind of figure things out and see what level of risk they are, you can decide kind of what you want to do with testing and treatment moving forward. That would be grossly different depending on your area of practice. In the inpatient setting, we would do something probably that's called a graded challenge. When you do a graded drug challenge, you give the patient a 10% dose of that antibiotic that they've reacted to in the past, or whichever beta-lactam antibiotic you would be thinking about using to treat their infection moving forward. So an example would be we commonly give Rocephin as a full 2-gram dose. We would give somebody a 200 milligram dose, monitor their vital signs closely for an hour, and then if there's no reaction, no symptoms, we give them that full dose, again, monitor them closely for an hour. If they're able to tolerate that drug challenge, they're more than likely going to do okay with that drug, and will probably subsequently do okay with several other beta-lactams moving forward, depending on that drug side chain. But again, recurrent reactions, as we talked about, can occur.
Mm-hmm. And then, so what do you do in the outpatient setting?
In the outpatient setting, I think these sometimes can be a little bit more labor intensive. Anytime you do a drug challenge with a patient, if you're giving them test doses and stuff, you should have their verbal consent documented. You also need to have quick access to emergency medications in the event that they would have a reaction to that drug.
And those would include?
Epinephrine, IM Benadryl, Solumedrol, and other steroids, albuterol, anything that you would treat an anaphylactic reaction with, essentially. And then the last thing is you need to be able to monitor the patient, which isn't always a doable thing in an outpatient office. You would need to keep a close eye on that patient for an hour. It's not someone that you can give that test dose to in the office and then send them on their way. Or you can't give them that test dose and put them in the waiting room. You would need to keep them kind of in an area where they could be closely watched. So sometimes the best thing to do, if you're not sure, if it seems more of like a moderate risk, like the patient's had like hives within the past 5 years, or it's a higher risk, like they've had anaphylaxis in the past, sometimes the best thing you can do is you've already talked to them about that allergy, you've documented what it is, you've established that it's more higher risk. Then you can start the referral process to have them see an allergist and get penicillin skin testing done. So with penicillin skin testing, it's just a simple antigen test where you do a scratch on the skin to see if they have a reaction or not. If that penicillin skin test is negative, they often will do one of those oral graded challenges to see how the patient does with the drug as well. Because false positives, false negatives can exist with penicillin skin testing, just like any other testing that you perform.
And an allergist office is certainly probably better set up to handle those emergencies
exactly.
than a regular primary care office.
Yes, they have all the tools that they need to safely do those types of procedures. They can keep a close eye on the patients. They'll probably have that appointment blocked off for an hour. So it's just overall a much safer environment for the patient.
But I think it's important because being labeled as a patient that has a penicillin allergy really limits the treatment availability for certain medications if they have certain infections. And so it's important for us to know and understand, is it a true allergy or not a side effect?
Absolutely. I think the biggest thing is that we see with patients with reported penicillin allergies is they often receive unnecessary broad-spectrum antibiotics, which can lead to more side effects, definitely less favorable side effect profiles when compared to a lot of beta-lactams. You also see a lot of people who have treatment failures or early cessation of treatment because they can't tolerate the side effects of the drug. And then sometimes these alternative agents aren't as good as the beta-lactams are at treating that infection. So it's very important to establish what these are. meaning what their reaction to penicillin was. And I think it's important to do it when they're just there for their routine office visit. You don't want this to be done at a time of crisis when you're trying to make your treatment decision. You could help a lot of people moving forward if you talk about this at the PCP office, especially if you're seeing a lot of elderly patients who maybe have memory issues. You want in there at that office with a family member or a support person who knows them. It's great to have it documented what their reaction is. So in the event that something happens to them in the future, that they're in an emergency room setting, urgent care setting with an infection that needs to be treated, that it's well documented what their reaction to penicillin was. So people can know that they can maybe safely use a penicillin or a beta-lactam on that patient depending on what their reaction was.
That's a great recommendation, just being proactive at determining this. Now, you speak on this subject and have written about it as well. What are some key takeaways that you want your viewers, readers, listeners to know after you speak to them about this very important subject?
I think ultimately I've kind of echoed it a couple times so far, is just having these conversations and documenting what the reaction is to the penicillin and, getting rid of these generic penicillin allergies in the chart. I often don't recommend deleting it from the chart because it often leads to this deletion and reentry cycle where, you take it out, but then they go to another office for some other reason in a month, and then they're telling that office that they're allergic to penicillin again. So you want to put your work in the chart. So document in that allergy tab exactly what you gathered when you talk to them. Be proactive, talk about it early, don't save it for when it's a time of crisis and they need to be treated. And then just intervening at your level of comfort. Like if you have the capabilities to do drug testing at your office, that's great, but make sure to do it in a safe fashion where you're closely monitoring the patient. You have access to emergency medicines. That patient has given you consent to do the drug challenge with them. And I think just thinking about this, and anytime you see a patient with an allergy to penicillin, just talking about it, I think is the most important step.
That's great. Alex, thank you so much for joining us today on NP Pulse. I love everything that you shared with us, and our viewers and listeners are going to really appreciate this. And this is something that we can all apply to our practice every single day.
Thank you so much. It was a pleasure to be here.
Thank you for appearing on NP Pulse, Alex. And thank you all for joining us today. Please subscribe to this podcast, share it with your friends and colleagues, and check back regularly for new episodes. And as always, be kind, be safe, be effective, and be the voice of the nurse practitioner.